We are back, having coffee, answering questions. Still kind of talking to myself. It's okay. We're early in this process, but we do enjoy giving the information. Today, we were going to discuss dry needling specifically, just because I had questions about what it was about. Off the top of my head. What dry needling is, when do you need it, when does anybody need it, what happens if you hear that dry needling is the dumbest thing ever or super dangerous. I mean, so let's just give some of the basic information. I'm happy to share. And of course, if you have questions, just pop in, ask away. We will be reiterating the topic. So dry needling is just a soft tissue technique. It's not super different in principle or in outcome goal. Oh, let me do one there. Let's just get my light on for you. Oh, there you go. There you go. Let me get to. That's what I want. All right, sorry. The magic of the internet. All right, so it is a soft tissue technique. Not different from what I would want to accomplish if I was using my hands to manipulate soft tissue, scar tissue, issues with muscle tension, muscle pain. The understanding currently, our best evidence understanding of what dry needling is affecting is this myoelectric signal for contraction inside of a muscle that otherwise really should just be relaxed. The understanding that we have right now is that if we have parts of our body that require amounts of stability that are normal for our day-to-day movement, and the muscles which are supposed to control that are get fatigued, maybe get injured because that can happen, or just start not being able to do their job very well, with other structures, other muscles, other dynamic stabilizing structures tend to get involved. And when they get involved, it just seems to be a little bit easier from a biomechanical perspective to turn little parts of muscle on and hold them in this on position than it is to just tell more of the system to sort of realign and stabilize. And as we get tired, our movement account, which we'll talk about here and there, goes down. Our ability to perform exercise or perform any kind of movement really that requires energy goes down. And so that is sort of that loss of the strong stability structure or strong core foundational contraction that is happening at all times. And so as we add load, more muscles, more things have to compensate for that increased load and the diminishing power or energy that you have on board. So we may develop these little areas inside of muscles that have now learned to contract to hold things together. And the longer those not supernatural, not natural ways for stability stick around, the more your brain sort of listens into this. Your brain is hearing what is going on at all times. And what typically happens with these kinds of folks, let's say get an example of shoulder pain. It's very, very common, especially because we treat a lot of baseball players and a lot of overhead and ground reaction athletes. So let's say shoulder pain, and very commonly, people complain of will complain of shoulder pain kind of aching in the front of their arm. They may have a focal thing like, oh, it kind of hurts here, push or hurts here, but for the most part, they're complaining of an ache, kind of a headache or a toothache. And what we'll do, of course, is we have to assume, if they're telling us something hurts here, we'll have to assess what's going on in this area. So if we can confirm that we haven't injured a structure that lives in this area by any number of our tests, we can confirm that we've not torn muscles, injured muscles, or done something to muscle structures that live in this area maybe recently that you can't point out or we can't recreate the pain, then I go, okay, if nothing here, right here, is wrong, well, what else can make this area hurt? And what we know, because of what I was just discussing with how our brain receives input from our body, this muscle in back, or several muscles in back here, part of our external rotator cuff sort of structure, refers pain to the front of our arm. And referral patterns are not something that's unknown. I mean, in fact, any one of us could probably find a place in our neck or our trapezius over here, these big muscles that if you push on it or you squeeze, you get a headache that sort of forms over here. Very common. It doesn't mean something is terribly wrong with you. It just means you may have a latent or active trigger point in that area, and you're just demonstrating your own referral pain pattern. That is the known place that this muscle will send pain if there are trigger points or these soft tissue contractions going on in muscle. So the longer those little contractions or contractures, or it's more like a contraction actually, stay there, the wider the receptive field becomes. And so the input from the brain is that, hey, there's a little something going on in my infraspinatus. It's getting a little bit more tight. It's getting harder. It's getting more permanent, let's say. Well, that's going up to your brain and is being received by a part of your brain that happens to be adjacent to parts of your brain that sort of sense this same area right here. And so we never have someone come in and say, oh man, right here, it really hurts here. It hurts when I externally rotate. We might be able to elicit their pain with forced rotation. Actually, that's sort of a giveaway. If we push their arm out and have them resist that motion, and then suddenly they feel this pain, I go, well, it's funny because in this position, there's no reason for anything in the front of this arm to be doing any work, real work. So we can then go into palpation and into examination of the muscles that we think refer or that are known to refer to that area. And then many times we find in infraspinatus an area that creates a comparable sign in the front of the arm. Now, that's a long story. That's how we get to what soft tissue changes that we are looking for. We examine almost everyone in the same way, but many times we will find, okay, look, yeah, I have a pain right here. It's right here. And when you point to a pain with one finger, that is very indicative of a focal injury. If you fall hard on your shoulder in a hockey game and you injure your AC joint, that's not going to radiate pain a lot of places. Unless it's been there for a long time, that next day, it's going to hurt right here. It'll feel okay in sort of these ranges. And then, that's really, really tight. That's tough. And focal injuries and focal catastrophic failure of, structures like ligaments are easy to recreate. So I could say, all right, I know what happens in the AC joint when we cross our arm. And if you have an issue in that area or pain or you've injured that area, that will be very, very painful. And so that's a giveaway of, okay, well, I had the instance, I can describe to you what happened, and then I do the thing that should recreate pain if I have injured that structure. Yeah, this isn't something we're going to dry needle. This is something we're going to help heal. We're going to optimize the healing process. So those things that you can point to with one finger, I have pain right here. I was lifting something and it hurts right here now, or I was moving around and it hurts right here on the inside of my knee. It only hurts when I bring my knee inward a little bit. That's very common, focal tissue injuries, and there's lots that we can do to help with optimizing the healing process. Shoot us comments and ask us questions about how to do that. It's actually stuff we do every day. It's super fun. All right, so now to the dry needling bit. We've sort of explained why these things happen, and this is just our best understanding of what the current literature says about these things. When we find an area that could require or could benefit from dry needling, pardon me, we will approach it with the technique. So the idea is we're going to use a very, very thin needle, extremely small, 0.2 to 0.3 millimeters in diameter, and they can be from 10 to 100 millimeters long. The length of the needle means nothing. You're only going to sense the tip and diameter of the needle, and actually these are very, very, very small, so you hardly sense that, frankly. Once the local area we're going to work on is found, let's say it's the infraspinatus, the muscle in the back, it's great. It sits right up against your another big bone, so it's a very safe area to work. We will tap that needle into the skin and then send it down to the level of the muscle, which in the case of that muscle is very small. And what you're trying to elicit is a twitch. The twitch is very similar to what you would experience if a doctor tapped you on the patellar ligament and it made your quadricep take off. However, this twitch is usually accompanied by the comparable sign, like, oh man, that pain on the front of my arm, I really feel it. Okay, that means that's somewhat confirmatory. That's somewhat diagnostic. Okay, great. I've created this referral pain, the pain they're coming in for, and I'm only hitting one spot on the back of their arm. I promise you, I'm not touching the front of their arm. So something is occurring. It's probably up here, in the crosstalk of the brain, which is normal and just part of the pain system. And we're trying to release the tension in that area. And the current literature best describes this as that local twitch response, sort of not allowing that contraction or that little micro contraction to be occurring at the same time. And when we relook at those same areas after we have elicited the local response, we see less of that jitter, less of that electrical activity in the area, and that usually corresponds with a little bit more exacerbation of some of the referral pain symptoms. But after a day or so, those really dissipate to the point where we're only needing to dry needle folks 2 or 3 times period, even after long bouts of pain that have been sort of scanned and x-rayed and, oh yeah, you're crazy, nothing's wrong with you, we can't see it in MRI, so therefore it doesn't exist. That's a whole other topic. Let's chat about how you're not your pictures, guys. You are not your MRIs, you are not your scans, you are how you move, you are how you feel. And we'll get into great detail about that, because that's one of the things I'm very passionate about. Like, we gotta stop being so reliant on pictures that are not great. There's lots of other things that we can do to make sure we get the full picture about how we move around and feel better about ourselves. So that, I think, let's see here. So dry needling, yes. Okay, the only other things that we need to sort of chat about are what you expect sort of after dry needling. You might feel a little bit sore, especially in the area and using the muscles that were dry needled. When folks, certainly we're giving them a lot of movement programming so that they can mitigate the soreness. It really doesn't last very long if you move around the area. So those are things that we just do to help it be more comfortable. I mean, it's already an uncomfortable-ish thing. I would not really describe it as any more uncomfortable than heavy pressure with hands or elbows, or however other folks are using techniques to get soft tissue worked on if that's necessary. So again, it's a couple of little things. This is not a technique that can be done everywhere. Unfortunately, there are still states in the U.S. that prohibit essentially dry needling done by physical therapists. And this is another topic for another time, but that is really can all be traced back to money and silliness. So whether it's an inability of a physical therapist to do it in California, therefore they're going to tell everybody who's ever got dry needling that that's stupid and you don't need it. Well, that makes sense. It's sort of silly for the brand of California PTs to say that dry needling is better than anything, because they certainly can't do it. Now, that's not because they are not safe. That's not because they don't get trained. California PTs are amazing PTs, and my favorite physical therapy colleagues are over in California. But dry needling is sort of there's a lot of political nonsense and having to do with other folks who also use a similar technique and a similar tool, but cannot maybe access the third-party payer structure. And so if I'm being veiled, it is on purpose. But in short, dry needling is a super useful tool, and if you are a therapist and you do it for good results, terrific. If you're a therapist and you don't do it and you still get great results, excellent. Let's just keep it, keep all on the same team, because we're all just trying to make people better. So let's see. That's pretty much it for me. I got a patient come in here right now, so we're going to get to that. You can shoot questions over. I think I get them in my inbox. We're still figuring out some of this live stuff. It's been fun, and just kind of a casual conversation. Bring your questions. I'll always have a topic. I'll try and do them every day during the week. So have a good one.